Hello, my name is Trevor Lentz from the Duke University Department of Orthopaedic Surgery and the Duke Clinical Research Institute. I'd like to thank the LeaRRning Health Systems Rehabilitation Research Network for the opportunity to present this applied learning case today. In this learning case, I'll outline how we've used real-world data to address a really important clinical challenge that we've encountered here at Duke. In particular, it's the need to develop efficient ways for evaluating and addressing psychological and mental health needs for people with osteoarthritis who are undergoing physical therapy in a comprehensive osteoarthritis management program. To provide a bit of context and really in an effort to give some background on the need that arose for us clinically, I'd like to talk a little bit about the biopsychosocial model of pain. And although this model has been around for quite some time, it's increasingly informed rehabilitation clinical practice guidelines, especially for chronic musculoskeletal conditions like osteoarthritis. The model reinforces the need to address not just the biological factors that I think we're all familiar with, like disease severity and inflammation, but also psychological and social factors that can influence how those biological factors in turn impact function, well-being, and quality of life. Osteoarthritis is really no longer seen as a condition that is limited to just joint degradation, but rather a condition that affects the entire person, both physiologically, psychologically, and also socially. And accordingly, we've seen practice guidelines now reinforce the need to take a much more holistic approach to care. It's probably also worth mentioning here that the rise in unsuccessful joint replacement surgeries, or those that don't provide the level of pain relief or functional improvements that patients want, have also driven more interest in understanding how we can better address the non-physiological aspects of osteoarthritis. So with this in mind, we've begun to see programs developed around whole health or whole person models of care. And these are called osteoarthritis management programs, or OAMPs. The Duke Joint Health Program is one of those osteoarthritis management programs. It began back in 2017 as a somewhat unique initiative where physical therapists, orthopedic surgeons, psychologists, dietitians, and pain management specialists came together to build a more effective care model for people with osteoarthritis seeking treatment at Duke. The program is designed as a longitudinal, personalized program that addresses not just the physiological aspects of osteoarthritis, but also the behavioral and psychological aspects as well. And what's really unique about this program is it was designed as a truly integrated, multidisciplinary program for people in all stages of osteoarthritis development, from those that had just initially developed osteoarthritis or been diagnosed, actually all the way through people that had undergone joint replacement. And the goal is that this would be a one-stop shop for the management of osteoarthritis within our entire healthcare system. Another unique aspect of the joint health program is the role of the primary osteoarthritis provider, or POP. In the joint health program, physical therapists serve as POPs, and their role is to oversee the delivery of care by identifying needs of the patients and then directing them to the most appropriate treatment. Treatment could include interventions that are typically provided by physical therapists, such as education, strength training, physical activity, training or education modalities, and also manual therapies. But it could also include referrals to weight management, nutrition, pain psychology, or sleep health specialists, again, in an effort to try to provide a more whole person approach to care. In the joint health program, the POPs are specially trained in cognitive behavioral theory-based strategies. And that means that they can incorporate psychologically oriented treatments like pain self-management, mindfulness approaches, guided imagery, activity rest cycling, graded exercise, or graded exposure, alongside more traditional impairment-based interventions like exercise. And this is really important, I think, at Duke, but also other healthcare systems, because psychological and behavioral health providers are extremely limited. So this effectively extends some of the psychologically based care that we can provide within our healthcare system. If you're interested in learning a little bit more about the joint health program, you can refer to an administrative case report that we published in the journal Physical Therapy in 2020. On this next slide, I've included a diagram to show a little bit more information about how patients typically move through the program. They would come in for an evaluation by an orthopedic provider. And as the function programs currently, those that are immediate candidates for joint surgery or have also exhausted other non-surgical options might be given an opportunity to undergo surgery, while all others would be referred into the official joint health program. In the program, patients would have access to the services that POPs provide that I talked about just a moment ago, or the POP may also decide that the patient would benefit from referral to higher level services provided by behavioral health specialists, psychologists, nutritionists, and weight loss experts. And I'll talk a little bit about some of the decision making around that in just a moment. But as we implemented this program, one of the major challenges for us was how to best evaluate behavioral and mental health needs and determine which patients might benefit from the psychologically informed practice delivered by the POPs, which tended to be a little lower level of psychologically based care, versus those that needed higher level services or more intensive services from a pain psychologist or behavioral health specialist. As I mentioned, formal psychological management opportunities tend to be in short supply. They certainly were and continue to be to some extent at Duke. So we needed to find a way to make the best use of these resources for patients that were most likely to benefit the most. And this led us to consider how we could use information that we gathered within the joint health program as part of usual care. In particular, information about psychological and mental health of the patients coming into this program to triage patients into the most appropriate care pathway. From the beginning of the joint health program back in 2017, the psychological assessment tool that we've used is called the OSPRO Yellow Flag Assessment Tool. And this questionnaire looks a lot like many other psychological questionnaires, but it functions very differently from other questionnaires. It's maybe better described as a calculator. And what it does is, using a 10-item questionnaire, 10 questions, the OSPRO Yellow Flag Assessment Tool can estimate what a patient would score if they were to complete these 10 different full-length psychological questionnaires that you see here on the screen. Many of you may be familiar with these questionnaires in your own clinical practice. These represent some of the most commonly used questionnaires to evaluate psychological and mental health needs in people with different musculoskeletal conditions. Although there is some overlap in these different constructs, the literature has told us that these characteristics are not all one and the same. And further, the number and type of psychological characteristics present seem to be really important for making clinical decisions about what to address. In other words, a much more thorough evaluation of these different characteristics like negative mood, depression, anxiety, pain coping characteristics like catastrophizing and fear of movement, also known as kinesiophobia, as well as understanding positive coping characteristics like self-efficacy, can help us better understand who's at risk for these poor outcomes. A major benefit of this tool is that you can get through a full assessment in only a couple of minutes, which is far shorter than it would take for patients to complete all 10 of these full-length questionnaires, which could take a very long time, and certainly is not something that could be implemented in clinical practice. Now, because this tool functions as a calculator, you can't simply add up the item responses to get an overall score like you would for other questionnaires or like patient-reported outcome measures. This one's a little bit different. It uses complex equations and algorithms to develop total score estimate. So it requires a computer-based scoring. One of the other nice features of this tool is that in addition to the score estimate that you get, it also can tell you whether that score estimate falls into the top quartile of the general population of people with musculoskeletal pain. This is what we would consider a yellow flag, or a psychological indicator of risk for poor outcomes. Those that fall into that top quartile, or those with yellow flag, may be the best candidates for psychologically focused interventions. For instance, in this example here on your screen, the PCS, or the pain catastrophizing scale, score estimate for this mock patient is 23 points. So what this is saying is that if a patient were to fill out the full-length pain catastrophizing scale, it's estimated that they would score 23 points. Now, that estimate, 23 points, puts them in the top 25th percentile or top quartile of the population of patients seeking care for rehabilitation with musculoskeletal pain. For that reason, pain catastrophizing may be something that's important to address during treatment. On the other hand, their score on the PHQ-9, which is a measure of depression, something that's commonly used in clinical practice to evaluate depression, was only 5 points. And in this case, it indicates that that score does not fall into the top quartile of the population, and it's well below, or it's below thresholds that we would consider to be major depression. So in this instance, depression may not be something that's worth addressing or needs to be addressed for this patient. What you see here on this screen is a scoring portal that we developed along with the Academy of Orthopaedic Physical Therapy. And you can go to this QR code here. It'll take you right to the website. It's probably worth mentioning that there are a couple of different versions of the OSPRO. There's a 17-item, a 10-item, and a 7-item version of the tool. We typically use the 10-item version at Duke because a lot of the research that we've done shows that it gives a lot of the same information as the longer versions, but without the response burden that you get with the additional 7 questions. We've also incorporated the scoring algorithm into Epic, and we distribute this questionnaire via automated Qualtrics surveys or through Duke MyChart, which makes administration and scoring of the tool very easy for clinicians. They go right into the note and they can see that information there, the score that the patient has on this questionnaire right in their note, and it's easy to import and make clinical decisions. On this next slide, I want to talk about how we've used information to inform screening and intervention as it relates to psychological and behavioral health. So how exactly are we using this information then to make the care that we delivered more evidence informed? So as I mentioned, the yellow flag assessment tool provides score estimates and also yellow flag indicators. And I've highlighted or circled those over on the right-hand side here. What we determine is that we can use these yellow flag indicators to help us understand common psychological profiles among patients that are seeking care in the joint health program. Essentially, we would be using this questionnaire to identify patient phenotypes. What exactly is a phenotype? Well, a clinical phenotype is a set of observable physical or clinical characteristics that together define a specific condition or of an individual or group of individuals. And in this case, the condition, if you will, is groups that are characterized by similar psychological distress profiles. If we consider that one of the major goals of a comprehensive osteoarthritis management program is to deliver patient-centered care, there's really an inherent challenge in delivering truly personalized, individualized care in an efficient manner, recognizing the constraints of healthcare delivery today. So what phenotyping allows us to do is, in identifying common psychological profiles, is develop treatment pathways that address the most significant or most salient psychological and mental health needs of population subgroups, while also allowing us to deliver these treatment pathways at scale. So how exactly did we identify or use the OSPRO yellow flag assessment tool to identify these psychological phenotypes? Well, we used a statistical technique called latent class analysis. And latent class analysis allows us to identify groups or classes of individuals defined by common underlying characteristics, in this case, their psychological profile. For this analysis, we wanted to identify these common profiles based on whether or not they had a yellow flag for each of these 10 different psychological characteristics. And we used data from the Joint Health Program, over 1,200 patients who had sought care over the course of a couple of years. And what this did was it helped us to understand what these common psychological profiles were. So I'll go through the results of that study here. And this study was published back in 2020 if you want more information about this. But what we found was that the first class, or the largest class, was what we described as high distress. Now, generally speaking, these patients in this phenotype had a high probability of having a yellow flag for most or all of the psychological characteristics we measured. They tended to have yellow flags for negative mood characteristics like depression and anxiety. They tended to have poor pain coping styles, meaning high pain catastrophizing, rumination about pain, really thinking about pain a lot and having it affect their daily activities, high fear avoidance beliefs. They also had low self-efficacy for pain management and low pain acceptance. This phenotype comprised just a little over half of the total sample, which quite frankly was surprising to us that such a large number of people were classified by this high distress group, but maybe not too surprising considering that most of these individuals have had pain for a very long time. So these are primarily individuals with chronic pain. On the other end of the spectrum, we had the low distress phenotype. And as you may imagine, these were characterized by very low probabilities of having yellow flags of any of these psychological characteristics we measured. This group was about a quarter of the overall sample. The next group, the rest of these fell into two separate phenotypes, two remaining phenotypes. And the first is this low self-efficacy or acceptance group. And this was about 15% of the population and really defined primarily by poor pain acceptance and low levels of self-efficacy for rehabilitation and for pain management. And then the final group and smallest group was one that was defined almost exclusively by poor pain coping strategies. And these are things like pain catastrophizing, pain anxiety, fear avoidance beliefs. So as I mentioned, if you're interested in finding or learning more about either this approach, this latent class analysis approach, phenotyping more generally, or these results, you can refer to that paper in Core from 2020. So now that we've identified these phenotypes, the next step then is to use that information to design treatment pathways that would address these common psychological needs. And as part of this process, 5 physical therapists within the Duke University health system met monthly for 12 months. We also received additional input from pain psychologists, pain researchers, and orthopedists about the best way to develop, design, and implement these different treatment pathways. I'm going to talk first about some of the key attributes of, or I'm going to talk about the key attributes of the treatment pathways in just a minute. But first, I want to talk a little bit about how these pathways were piloted in the Duke Health System. After developing these treatment pathways, we trained the Joint Health Program POPs on how to use the OSPRO Yellow Flag Assessment Tool, how to determine phenotype assignments based on the yellow flags that were present, and then also how to make decisions for treatment and referral. This was done through a variety of different methods. We used presentations at quarterly meetings. We developed some case vignettes to show how you might be able to do this for different types of patients. We used print or electronic materials that we distributed out to the POPs that they could have by their computer or have hanging in their clinic. We also built documentation smart phrases into Epic, and this served a couple of purposes. Number one, it was to help remind the POPs about the opportunity to help phenotype these patients using the OSPRO Yellow Flag Assessment Tool. But it also made documentation a lot easier, so it's something that we could track on the back end. And so a major goal also was to help standardize treatment, which we knew would be important for assessing whether or not this approach to decision-making brought any value to the clinical encounter, either for patients or for POPs. And to help us understand the POPs' experiences with delivery of care, targeting these different phenotypes or using these different phenotypes. So we also administered pre- and post-implementation surveys 6 months apart to assess comfort and confidence with using the assessment tool and making decisions about treatment and then delivering tailored care. What I don't have here on these slides is the result of those implementation surveys, but what we found was that over the course of the 6 months, POPs reported that their their comfort level and their experience level with delivering this level of care significantly increased, which we found to be important and also encouraging when it came to really trying to expand this model of care within Duke Health. To develop the treatment pathways themselves, we used a framework that we had published in 2021 in the Journal of Orthopaedic and Sports Physical Therapy, JOSPT. Essentially, this is a stratified approach to care where individuals with low impact of yellow flags or no significant yellow flags, this is over on the far left-hand side here in green, they would receive more standard physical therapy. So in this case, standard physical therapy may include even just an initial evaluation, education, a home exercise program, and follow-up as needed without any significant in-person care. On the other hand, on the other end of the spectrum, over on the right-hand side in the red, for those where we identified signs of severe mental illness, such as the case of clinical depression or suicidality, of course, this is indicated for an immediate referral to psychological treatment. For individuals without signs of severe mental illness or when emergency psychological care was not indicated, but the patient still had significant mental health or psychological health needs, the POPs would initially begin the psychologically informed approach to care and then consider referral to a psychologist or other behavioral health specialist if needed. This is indicated here in the middle column with the orange heading, the PIPT, with referral. And so in this case, together, the POP and the psychologist, if there was a referral, would work together to address the psychological needs of the patient. For those individuals that didn't fit into these other three categories, those that maybe had a moderate impact of yellow flags, but no real significant symptoms of mental illness, the initial plan of care would be to initiate psychologically informed physical therapy, where the physical therapist or the POPs were delivering CBT, cognitive behavioral-based treatments, mindfulness, and other psychologically focused activities that would help to improve self-management, in addition to the more traditional impairment-based physical therapy that would include things like exercise and strengthening, what we might traditionally think of as physical therapy. So with this model, this conceptual model of developing tailored care in mind, let's talk a little bit about the key attributes of the different tailored treatment pathways that we developed based on the phenotypes that we identified. And this is a lot of this is informed by the published literature and what we know from the published literature about what different types of treatments are effective for treating different types of psychological characteristics or profiles. As a reminder, we identified these 4 different phenotypes: high distress, low self-efficacy, and negative pain coping. For those in the low distress group, treatment would look very much like the typical physical therapy, where patients would receive impairment-based interventions, education, and self-management. Because they don't have high psychological risk factors for poor outcomes, treatment could also be relatively straightforward in terms of the amount or intensity of care that they're receiving, an initial evaluation, education, and then follow-up as needed. Within the program, these patients are seen as maybe some of the best candidates for telehealth follow-up and even telehealth evaluation as that's allowed or appropriate. For those in the low self-efficacy phenotype, treatment would focus on improving self-efficacy. So it would include things like value-based goal setting, accountability check-ins, and providing opportunities to really have these easy wins for the patients. What we think is that a lot of these individuals have experienced pain as a result of their osteoarthritis. They may be doing far fewer activities than they were used to doing, but by helping them to understand that they can do things that they didn't think that they could do, that this will get them on a path to recovery. So the possibility or the probability of them transitioning from a low self-efficacy phenotype to a low distress phenotype is probably pretty high. Those in the negative pain coping phenotype were provided with a slightly higher level of cognitive theory-based therapeutic strategies. And these would be things like graded exposure, graded exercise, pain neuroscience education, and activities that are designed to reduce the threat of pain. In essence, we want to try to change the way that people think and feel about their pain, their cognitions around their pain. For these individuals, we want to increase their activity levels. We want to decrease the perceived threat they have from doing their normal daily activities that we know is most likely not going to hurt their hip or their knee with osteoarthritis. For those in the high distress group, we've already talked just a little bit about how you might manage the high distress group. Those would typically be given the option of co-management with psychological or behavioral health. It's important to kind of highlight that this is not an immediate referral to a psychologist or behavioral health specialist, but that type of conversation enters the discussion when the POP is talking about treatment options with the patient. So they would be given this option for co-management in addition to the use of psychologically informed techniques that would be used for people with low self-efficacy or negative pain coping. So we're really taking those approaches and also applying them to the high distress group as well. Although treatment for those in the high distress group would include more traditional interventions like exercise and physical activity, again, the goal is to get them more active. Their approach tended to be a little bit more psychologically focused than some of the other phenotypes. So since the purpose of this case study is to outline some of our implementation experiences and our experiences using data with real world data within a healthcare system to try to improve the care that we're providing, I wanted to talk a little bit about where the program is now, some of the challenges that we are having, and then where we plan to go with this. So some of the challenges that we are addressing at the moment include understanding how to best document care so that we can study the outcomes of this approach retrospectively. Because if we don't have good documentation of not only what phenotypes patients tend to fall in, or that the type of care that's received, it makes it really difficult to understand whether this approach improves outcomes overall. In addition, we're trying to understand which of our assessments add the most value to care decision-making, and are there ways to pare down what we collect. Right now, we collect a lot of different outcome measures. We collect a lot of different information about the patient as a whole person. We're trying to get a better understanding of what information helps us with decision-making the most, or is most vital to decision-making. We're also trialing the use of tailored care, and we want to understand the feasibility of delivering this tailored care at scale, because right now a lot of it is really based on theory that we think that this approach is going to be helpful for patients, but we don't have a lot of those outcomes yet. So that's certainly something that we are interested in understanding, and also understanding what types of resources may be required for delivering this level of care. It's really a challenge, I think, within the electronic health record interface to understand or to really collect data that helps us to understand the benefit of this approach. And for sending out the surveys that we use to look at outcomes right now, much of that is done through Qualtrics or Duke MyChart. However, one of the things that we are challenged with, and I know that a lot of other healthcare systems are challenged with, is low follow-up rates, because we don't necessarily have staff that is following up with patients to make sure that they are completing questionnaires at 6 months and 1 year. And so what we want to try to do is improve that outcome response rate. And we're trialing some different things to help doing that, including sending out email reminders and having POPs reach out to their patients to try to remind them that this information is really important, in addition to doing that when they enter the program, so that the patients, as they're going through the program, recognize the importance of these outcome measures. We also have a number of plans moving forward, so where are we going? One of those is assessing the acceptability of tailored care processes among patients. In the joint health program, we focused a lot of our early implementation work on understanding how to talk with patients about mental health and psychological needs in a way that isn't stigmatizing. So a lot of what we were doing is trialing this language to understand how we can help to get patients on board with this level of care, which may be something that they're unaccustomed to when seeking out physical therapy. And we continue to improve upon that process. Obviously, we want to identify opportunities to further streamline care. I think that's the goal of just about any healthcare system is streamlining care and making sure that the right person is receiving the right treatment. We are also trying to understand how we can reduce wait times for specialty services such as pain psychology, nutrition, and weight loss. I think in most healthcare systems, the wait times for these specialty services tend to be long. And so we are trying to understand how we can deliver certain components of that care in the meantime while they're waiting for their specialty care visit. A big part of this is understanding who is most appropriate for these services, and that's another one of our goals. Another goal is to really understand who is most appropriate for the joint health program altogether. So there may be individuals that are most appropriate for kind of a more traditional musculoskeletal physical therapy care pathway versus those that need higher levels of services, and how exactly do we triage those patients so that they get on the right care pathway. And then finally, we want to understand whether, again, this tailored approach delivers better outcomes. What we know is that there's a lot of theoretical support for this. There's some encouraging early literature to support risk stratified care, but there's also some literature to suggest that risk stratified care may not result in better outcomes. And there are certainly questions about its effectiveness, certainly in light of the increased costs that are often incurred by by delivering this higher level of care. So in closing, I'd like to thank just a group of clinicians here at Duke University who are really instrumental in developing the Duke Joint Health Program and in conducting this work to help identify phenotypes and develop these tailored clinical care pathways. And then finally, just thank you for your interest in this case and encourage you to reach out to me if you have any questions. I'd certainly be happy to talk through any questions that you might have. Thank you.